with that, I will start off with introducing our HPNA representative panel, and this is our panelists are representing not only HPNA, but the interdisciplinary team role. First is Alex Wolf, who's a doctor of nursing practice and an advanced practice registered nurse as well out of TriHealth in Cincinnati. And Alex is going to be representing our APRN voice on our panel today and is actively involved in the Ohio Palliative Care and Quality of Life Interdisciplinary Council and several published journal articles throughout the country on a national level. So Alex, thank you so much and welcome to the panel today.
Great to be here, thanks.
And our second panelist is my fellow Alabama nurse, Eunita Robertson. And Eunita is the clinical director for Encompass Hospice out of, well, actually all of Alabama, and is certified hospice administrator. She's also a certified hospice palliative nurse, administrator for Encompass Health, and has been instrumental in getting end-of-life education voices and messaging out there and training in the state of Alabama for over 30 years. And Eunita, I can't thank you enough for joining us today. So you'll be representing our RN voice from HPNA. So thank you.
Well, thanks for having me.
All right,
Natalie?
Yeah, so I'm Natalie Kovacic. I'm the program manager at SWHPN. I help manage our educational programs, including webinars like these. And so I'm really pleased to welcome two of our members today of SWHPN. The first is Becky Cammy. Becky is the supervisor of patient oncology support services at the Sidney Kimmel Cancer Center at Thomas Jefferson University. She's worked extensively providing clinical psychosocial support in oncology and palliative care and hospice. She's a board member for the Research Training Institute with the Cancer Support Community and an active member of SWHPN. She's on our board committees for education and is a speaker at our conferences, and we're so glad to have her here today. And our second speaker is Yoonju Lee. Yoonju is also a licensed clinical social worker. She has experience in labor and human rights in her native Korea and has worked with Asian American domestic violence survivors in New York. She's worked in palliative and hospice care for the last 12 years, and she's currently a palliative care social worker at Memorial Sloan Kettering Cancer Center in New York. So welcome Yoonju and Becky to the panel today.
Thank you.
And I'll just talk very briefly just about SWHPN. So for those of you who aren't familiar with our organization, SWHPN is an organization designed specifically for social workers to bridge the gap for social workers who are working in end-of-life hospice and palliative care. And so we want those social workers to have a voice in the larger field. And so that's what our association is. And you can find more information on our website at SWHPN.org. And I'll hand it back over to you, Julie.
Well, thank you. Today we're going to take questions from all of our participants on the call. And so if you would just type those questions into the chat box, and then we will facilitate getting them over to our panelists to respond. And we'll just go ahead and get started. So I'll kick it off with our first question, which is to our panelists. And they would appreciate both the nursing and social workers' perspective to this question. I've been in conversations with many practitioners on the front line, and a common theme I hear is that there is limited to no options for closure for both the patient and the family, as well as the teams caring for them during this time of crisis. How have you adopted your practice to address this loss of closure going on in the presence of COVID? So if we could open up to Eunita and Alex, and then we can move over to our social workers. So Eunita?
Okay. Yeah, that's very interesting, the whole aspect of closure, because, you know, in hospice, touch, the family involvement, being present, really is at the very core of what we do. And so it's been very challenging, I think, to come up, with alternate ways to be able to provide effective closure. So some of the things that we have done recently, we've adapted the concept of doing porch visits. And for those that are not familiar with that, it's trying to provide a visit while maintaining our social distancing. And typically, it being in the South, it's been warm. And so if we can get people outside, we actually do that while we're in the yard and they're on the porch. So that's been quite successful. Of course, Zoom, everybody loves Zoom, and we are very, very familiar with it now and how it works. We've also done a lot of our support groups via video, such as Zoom, and of course with phone calls. Lots of facilities still we're not able to get into right now, and so we've been doing a lot of phone calls there.
Well, thank you. And Alex, what are you looking at from an APRN standpoint in Ohio?
Well, first of all, Eunita, I wanted to put it back to you for a second. It sounds like you, and I apologize, I did see the slide briefly, but it sounds like you're in a community setting. I mean, you're seeing patients in it sounds like is that a nursing facility setting where you're talking about the porch visits, or are these home visits that you're talking about?
This is actually a home health and hospice visit. Okay. So we're out in the community.
Well, the reason I ask is because I'm a nurse practitioner in a strictly inpatient role. So I'm only doing inpatient palliative care consultations in a hospital setting. So I just felt like for the people listening, it would be helpful to know the differences between what you're doing and what I'm doing. So, I would say similarly to what you said, I think very quickly we've seen our health system basically adopt Zoom and FaceTime and Google, I forgot the name of it off the top of my head, Google Duo. So we're having to be very flexible and nimble with all these different digital platforms, but similarly, it's challenging. I wanted to briefly just tell a story of just kind of a way that we have had to adapt a little bit. As I said, I do inpatient palliative care consultations, and I had a patient recently, and I have to be very careful with HIPAA here. So I don't want to disclose whether it was a COVID patient or a non-COVID patient, but it was a patient who very unexpectedly had a cardiac arrest and ended up in the ICU. And because it was very unexpected, the patient was not allowed to have visitors at all during her hospital stay. And then all of a sudden, she has a cardiac arrest. She had a very grim prognosis after that. And if I'm not mistaken, I think she had another subsequent arrest and did not survive the arrest. And then I was notified in the morning after this had happened about what happened. And this was a patient who was actually very well known to many of the units in the hospital. She'd been in the hospital a lot. And long story short, it brought a bunch of issues kind of to the forefront that we hadn't had to deal with in a long time. For one thing, the family had not been allowed to visit. And then all of a sudden something horrible happened. And now the family's allowed to visit. So it's this horrible sort of double-sided, like, hey, you get to visit your loved one, but it's because they've died. And it was horrible. I mean, we are being introduced to the family post-mortem. And I think it was also very tough on the staff, because this was, again, a patient that was known to them who, they'd talked to before. And now the patient has died. It was an unexpected death. And now I think our role as the palliative care team became about supporting the family and supporting the staff post-mortem. And we did something that I thought was really special. One of my friends from UVA, some of you guys might be familiar with, his name's John Bartels, and he helped pioneer this thing called the pause, which is basically just a very short way to honor an individual who has died. And it's very short. It's literally just saying their name and how old they are, and just recognizing that this was a person who loved and was loved. And when we did it, it was very organic. I didn't know what else to do. And I thought, well, maybe we should do a pause. The family's here saying goodbye. Maybe we can get their permission to have like a staff moment with the patient and with the family to just say, this was so-and-so and this is who they were. And I honestly wasn't sure how it was going to be perceived by the staff, but I asked the nurse and she said, no, that sounds awesome. Let's do it. And we went in and we asked the family, like, do you mind if we invite the rest of the team in who helped to try to resuscitate your loved one? Can we do this thing called the pause? And it was very short. I had it all up on my phone, and we just did this very quick moment of honoring the person who died. And it was really special. The family was blown away because here they are dealing with a very unexpected death. And to have a whole team of people come in and kind of rehumanize a very dehumanizing situation was really special. So my point of all that was to say the pause was a very short and a very powerful way to sort of, adapt to a very horrible set of circumstances that we're all dealing with.
So bringing that closure at a time. Thank you, Alex, and thank you, Eunita. So Anju, what are you seeing in your practice?
So I
Regarding
appreciate Alex's noting the importance of just taking that minute and doing a ritual. What we know about loss, especially this kind of loss in the context of COVID, which is, what we would call sort of ambiguous loss. If we lost a loved one and we weren't even present, did they really die? The last time I saw them, they were going off on an ambulance. And then the next thing you hear is come at bedside, or you get the phone call, and families have we in the hospital, we've certainly made efforts to try to do FaceTime, to try to, sorry, somebody, try to do FaceTime, or try to do iPad meetings and have, nurses go into the rooms all, with PPEs and facilitate that conversation. But, most of them are intubated prone. They weren't getting the last words. They weren't being able to hold their hands. All of the rituals that we find so important in end-of-life care. And so I think that created distress for both the clinician and, of course, for the families. And so I think because of that, because of not just the way in which patients had to die alone, but the number of deaths that our clinicians were seeing, we were sort of all at this sense of hyperarousal. We were in do mode, and the importance of, as Alex said, to take a pause, to mark this moment, to ritualize, what we would say is ritualize a death, to actually do something to externalize the fact of this death, I think is an important thing that we need to do. And I think it also highlights the difficulty of what we call closure anyway in grief. We know now that there's no such thing as closure. We integrate the loss in our lives, and then we make meaning out of it, but it's a lifelong process. It's complicated by the fact that families can't get together to do a social ritual and have a public display of loss. And so I think the fact that all the clinicians were able to give public display is a really wonderful thing for our service, for our team members. I think this kind of ritual, even if it's by Zoom, is very important. Little symbolic things like, one of the things we've done in our service is provide a rock as something to hold on to as a signifying of loss. So small rituals, private rituals, large rituals, I think are really important to mark something that can just bypass us. And I think, unfortunately, part of it is that this country as a whole hasn't mourned the 130,000. The country has not had a moment of silence, even marking that. And I certainly, as a hospital, as a hospice, I think those are all important ways in which to mark this loss.
Thank you. And Becky, what are you seeing from your practice?
Sure. So I work at an outpatient cancer center on the outpatient palliative care team. So that's my setting. And while we've found really novel ways to screen and triage and provide telehealth visits to our patients, I think this finding closure piece has certainly been more challenging for us. And I certainly personally struggle with this. We just had a case over the weekend where a patient who died very suddenly over the weekend, and she didn't have COVID, but due to COVID was only being seen and connected with her care teams through telehealth. And our palliative care team actually had a telehealth visit with her on Friday, so just 24 hours before she died. And we're all, quite shocked. She was still in active oncology treatment at this time. And so it raised the question for us of what did we miss here, or did we miss something here?
Mhm.
And had we been able to see her in person, is there something that we would have caught and potentially followed up on that may have kind of contributed to her death? And so I think that kind of distress is among the team in terms of the closure piece of her death, and sort of thinking about if we're doing everything we can. And while telehealth has been a wonderful resource for us, it certainly has its own limitations, and can make the cases a bit more challenging to be sure that we're providing the best quality care. So it's challenging, and I hear also echo the kind of concerns among the closure about the family members. If we're struggling as team members about how we're closing with patients, certainly we're noticing that the bereaved are struggling as well, and those who have to have limited attendance at funerals, or cannot have the community support that is sort of traditional in their religion to be able to grieve these losses, is certainly contributing to the isolation for those who are in grief right now. And so kind of just recognizing the complications with the families as well is important.
Thank you. We had some really great comments come in from our listeners. Stephanie had made a comment about our families who die at home. Many extended friends or relatives also have been absent from the dying, death, and the funeral processes. Our funeral homes have done an amazing work allowing creative funeral rituals, and those are the stories I think that we really should be sharing, is what are those rituals and what is that amazing work. So thank you, Stephanie, for sharing that. And Caitlin is a social worker in an inpatient unit, and had said that so many of her families have expressed appreciation for allowing family members to visit them when they come from nursing homes or hospitals where they could not. So I think that it's different practices within different institutions. Some do allow and some don't. And that can be in itself complicated, because why could I not go see my mother, but yet you could go see yours? And so those are additional thoughts that have come in from the chat room. And then Judith had a question for the panelists, and I'll let you, y'all can pick as to who wants to go first. How can we as professionals try to prevent the long-term effects of COVID-19 isolation, especially to our patients who are having exacerbation of depression and isolation? So preventing the exacerbations of depression as a result of isolation. What is being done in the field differently because of this?
All throughout this COVID experience, I've reflected on sort of the parallel process of being faced with an event that's sort of outside of my control, which is an illness that for all of our patients is something that happens externally that's outside of their control, and then trying to manage that initial shock to some kind of way in which we need to now manage our treatment and have hope and do all of the end of life work. And so reflecting on that parallel process, one of the things that I faced myself that I could reflect back on what it might feel like for all of our patients, that sense of isolation, because illness is certainly an isolating factor. And that one of the things that I think we can help our patients and people who feel alone and isolated and depressed is, one is accepting the fact of this COVID situation, which we are going to be in the midst of for months and months and months, right? It's not ending anytime soon. So instead of resisting, and I found myself resisting and not wanting this, and how much damage there was done to me by trying to resist rather than accept and make meaning and then shift. And really bring to them that understanding that this is nothing we can do. We need to accept, and then find ways, clear strategies to live out this time with intention and paying attention to how we are doing in that time. So I had some mantras, and I think they can apply to everybody, which is, one of the things that we know to build resiliency is to be in our bodies in a way that's healthy. So get out, exercise, do something that you can move your body. To be able to find some joy in your life is really important, to focus on some things, concrete things, to connect, even if it's Zoom or phone calls, to connect daily. And we as clinicians can certainly reach out more often, and we have, I'm sure, so that there's always some sense of human connection, to sort of make sure that the isolation isn't so deafening. But really speaking to them about strategies in which they can maintain their time, manage their time with real intention, so that it just doesn't slip by and just this, habitual watching TV and, sleeping too much, or not, all of these rituals that can be so maladaptive and in the end add to these depressive factors.
At my cancer center, we really noticed the isolation among the patients who were inpatient and not having their family members visit. And we created a program that I think is fairly unique in utilizing all of our medical students who were home and also, eager to connect with others and learn and connect with patients. And then we have these patients here who are eager to connect with people, and had them make just outreach calls to our inpatients. And there was really no agenda. It was just to have a friendly conversation. Certainly if needs or other concerns came up that required a social work referral or some other kind of level of care to be addressed, they would refer accordingly. But it was a really nice opportunity to utilize the medical students to be able to connect and provide that support as additional team members. And we did just like a little scale of anxiety a distress score that we did before and after the visit. And also got some narratives from the medical students about what the experience was like for them, because they did find it quite rewarding. So there was a little bit of a research kind of component in the backdrop of this as well.
That is so cool, Becky.
Yeah, that's neat.
Yeah, because my wife and I were just talking about that. She's a resident, and she usually works with medical students. And I think, talk about a loss of role. I mean, a lot of our medical students in our community anyway, basically just kind of very abruptly got sent home. And I wondered if all of you guys had this experience, but like, it sometimes feels like post March 15th, I would say, it seems like the most palliative interventions I've provided haven't been medications or big family meetings or, major changes in the goals of care. I mean, yeah, that stuff still happens, but the major, like, when I go home now and think, wow, I really did a great job today and really made somebody feel better, it's usually from just the act of like being able to sit down and socialize with somebody. Or like I see patients on an inpatient geriatric psych unit. So many of them have dementia, and they have plummeted during this time. I mean, I'd actually love to hear more from some of you who see patients in long-term care settings about this, but it just seems like cognitively many patients have severely deteriorated from their families not being able to do their usual, as you said, rituals, their usual family rituals, having dinner a few times a week, and kind of helping anchor the patient to reality a little bit. That's not happening as much. And I've seen so many patients who, the theme I hear all the time from families is, mom has just she's been like a completely different person the last 2 to 3 months. I mean, it's like she was totally stable, and now she doesn't recognize anybody. She's acting out all the time. She's incontinent. She's doing all this stuff she's never done before. And it's like been a very rapid decline. And now they're on a geriatric psych unit, which is very sterile and, loud and scary. And sometimes what I've found anyway is just something I'm not used to doing, which is bringing an iPad with me and just, talking to the charge nurse, talking to the bedside nurse and saying, hey, do you think it'd be okay if maybe I allowed, her daughter to say hi to her? Is that going to agitate her? And, sometimes it does. Sometimes it actually goes really poorly. But more often than not, it's very emotional, for one thing, because it's, the family's telling me, oh my gosh, I haven't seen dad in months, and this is the first time I've seen him. It's the first time I saw how bad he is now, how sick he is. And but more importantly, I think I feel like the most palliative intervention, as I said, that I've done recently has just been that even the digital connection, just the simple act of putting the phone up to somebody's ear so that they can actually talk to their family. And at least in the inpatient setting, I'm doing a lot more of that.
And those are all really good points. And I would just like to add something from the hospice perspective. You know, my organization and a lot of my colleagues really have noticed, as you said, somewhat of a decline in patients' cognitive status, especially those that have the Alzheimer's and are in facilities. And so some of the things, and I'm sure a lot of you have seen those on TV and the news and things like that, but just allowing the patient to be positioned in the window, you know, so a family member can come up and talk to them, even if it's through the glass, we found to be very helpful. And other things, like we have a volunteer program, and we've like had them make nice colorful cards and things like that to show them, even though it may be, you know, digitally. I mean, it's still I think means a lot to them, and anything that we can kind of do to help them become a little bit more interactive, or at least being present, I think is really key to keeping them, you know, cognitively still kind of there in the moment. So I think all of those things that were mentioned, and some of the things that we're doing too, I think have been very helpful.
Anyone else? Okay. So I want to ask a follow-up question to that. Stephanie mentioned in the chat, there's a lot of great comments in the chat. If you can get in the chat, you should. And actually, I will download this chat and send the text to everybody after with the recording, because I think there's a lot of great comments in here. Stephanie asked a question about the racial disparities and how that affects the trauma of what is happening collectively. But I want to ask that specific question about, you know, what do you see as the long-term effects of this for nurses who have interacted with these patients and families, as social workers who are interacting with patients and families? What do you think the long-term needs are going to be to address the grief and the isolation and the counseling needs that are going to be for clinicians and for families of patients? What do you see happening? And because it's clearly not over yet. So what do you see as kind of the future of and maybe some interventions that can be done now to address it? I just wanted to hear everybody's thoughts about that. Anyone?
Well, I'll start. I think that it's important, you know, especially with clinicians, to really know how they coped with things and their resources pre-COVID, to sort of know how they may or more likely to react during and after this event. And so I think one of the, that's one important thing that we need to look at. And, you know, with lots of nurses, in many places, like in home care, for example, while visits have fallen off a bit, in those high acuity care situations in hospitals, I would think that there's going to be a lot of burnout for nurses. And so I think that's something that's very important that needs to be looked at. A lot of separation anxiety. And again, going back to a person's past experiences, I think that there are those that may be more prone to substance abuse issues and PTSD.
Yeah, I was gonna say, I mean, I think the first step is recognizing and acknowledging that this is a trauma, and it's a trauma for our patients, it's a trauma for the families, and it's a trauma for us as the healthcare providers. And actually using that language and calling it such, I think, is important. I mean, a trauma basically means that there's feelings of powerlessness and helplessness and feeling overwhelmed, which I think many can relate to in this experience. And COVID has certainly given us an extreme amount of uncertainty in the world and in our lives. You know, we have, as providers, we're worried about our own health, we're worried about exposure to our families, but we're also at the same time worrying about our patients and trying to figure out ways to best support them. So that's a lot to kind of grapple with. and can lead to, you know, quite a bit of moral distress around trying to balance our needs with the needs of our patients. So I think, you know, it's important that we are recognizing that right now we are practicing in really less than kind of ideal situation here, and that there's probably a great amount of guilt that many are feeling, that perhaps that they're feeling that they're not doing enough in this situation. And so I think sort of being honest with that perspective has to kind of be the first step before we can kind of figure out exactly how to support people through that. But I think the lens of this being a trauma is certainly important.
Okay, so I'll ask a few.
So let me, I think the trauma lens is certainly important. And if we use that trauma lens, what is required, I think, additionally later on, when this is whatever, whenever, and however you define sort of closure, because I think it's not. But I remember in the very beginning of this, one of the questions that I had read and talked with my colleagues is, who will we be after this? So there's a disruption, an external disruption. And the goal, I think, is not to return to normal, but to be better than, especially in the current racial political climate, that there's a real recognition for a need for things to be different. And that COVID has really exposed a lot of the fault lines in our society, all of the things that could go wrong, not just in our society, but certainly in medical situations. I mean, the fact that this wealthy country was fighting for PPE still blows my mind, right? That we can't do testing blows my mind. And so you have to ask about the structural questions about how did we get here? And then what can we do better? And I think that that's at a macro level, but at a micro level, it is how can we make meaning out of what is happening, right? So David Kessler wrote early on about the sixth stage of grief or loss, which is about meaning making. How are we going to take this experience, incorporate it, and become better in post-COVID, so that we understand better how to help and support our patients and be a better citizen of this world? I think those are things that we really should focus on, because we know also from trauma that there's an important factor called post-traumatic growth. And I'm hoping that with all of our help, that we can get folks there to a better place than where we were. And I think that's the hope. And that's really sort of, for me, the light that sort of shines on all of this experience, that gives me hope and is something that I still need to work on in the future with colleagues.
That's great. Yeah,
I agree. I'm sorry.
Go ahead. I just wanted to ask. Go ahead. You go first, Julie, and then I'll ask my question.
It wasn't me.
Oh, it was someone else. Sorry.
It was me. It was Atika from Business Physicians in Ohio. I just wanted to add to, I think I'm not sure how to pronounce her name.
Yunju.
Okay. But I think it's very important that during these times that we look at the diversity and inclusion, and as clinicians, we need to have a better understanding of that, because that will allow us to service our patient population better, because there's a huge disparity when it comes to the medical treatment. And, it's no shock to anyone what's going on right now. So just try to add that on top of this COVID-19 crisis. So you have people of color that are feeling very stressed out. And it's definitely a post-traumatic stress issue, because they were like, not only are we being attacked in one area, but then there's a difference in the treatment. So that's another thing. I think that if we equip ourselves with a lot of cultural and diversity training, and that's the include, the LGBT group, like all of that's encompassed in this, then we can service our clients, our patients, and our patient population a lot better.
Yeah, thank you. That's a great point. And so I was gonna say that to follow up to your question, I think you said your name was Angela. To follow up to your question, is there anything your institutions are doing, Eunita, Alex, Yunju, or Becky, to address that? Because we know that Black and brown people are dying, twice as, I think it's twice as much as the rest of the population from COVID-19. There's a clear disparity there. And are your institutions doing anything to address that? And especially now that it's kind of in the forefront of our consciousness, as Stephanie and Angela mentioned in the chat.
So, being in New York City, it's certainly not lost on us that this COVID has hit disproportionately communities of color, especially African Americans. I think the statistics are, they make up, African Americans make up about 14% of the population and make up about 34% of the deaths. And I think that's really a shameful reality. And we are speaking as a hospital because, there are protests across the street from the hospitals, and there have been throughout post George Floyd's death. And so we can't be insulated from both those facts that African Americans have disproportionately bear the brunt of this illness. And there's, as Angela said, in addition, there is the police brutality, which is taking more lives. And so we can't help but have those conversations. So we're having them everywhere from very small changes like being very mindful about when we use the word health literacy, is that code for something? Being mindful of presentations when we are assuming someone is a person of color and not naming it, and what is the implicit narrative in those things. And then at a meso level, really looking at hiring practices and making sure that we have a representation. And my hospital, I mean, to be very frank, is a very elite hospital. It is underrepresented in terms of, I read, I think Black African-American physicians are 4% of the population of doctors. That seems to me really a shame. And so from micro to macro levels, we need a whole swath of change, certainly among clinicians, to have conversations about race and health disparities and social determinants of health, to really look at those aspects that whether African-American communities and why they are dying at higher rates with comorbidities, the idea of transgenerational stress, the idea of, sort of just chronic trauma. Those are things that I think we have to be part of our lexicon and understanding and shifting. Again, how do we do this better so that it doesn't disproportionately affect our communities of color? And what does social justice and racial justice and the healthcare system look like? And I'm hoping that there's a renewed commitment I see certainly from my colleagues, and hopefully at a bigger institutional level.
Eunita, or Yunju rather, one thing that I've noticed at our hospital, kind of along that same line, I think, is ever since George Floyd died, and we've seen a large number of protests worldwide. One positive thing I think that I hope means that George Floyd did not die in vain is that I've noticed that it seems to me like, and I speak as a white male, and I think it's very important to acknowledge this bias, and I encourage anybody to tell me if I'm speaking out of turn, but I've just noticed that race and what it means at a fundamental level to be Black in this country, and how different it is, how you're treated by everyone from law enforcement, health institutions, every institution really. I think now, personally anyway, I've noticed that it's something that we are now talking about at an individual level on a more frequent basis. I think these are things that I know I read about in textbooks and in news articles and on Twitter and on on social media, but I felt like it was something that with my colleagues, particularly my colleagues who were racial or ethnic minorities. That's not something we talked about. We kind of tried to stay away from talking about things like that. And I've noticed that in the last month or two, we felt more comfortable talking about it. And I think that's a very good thing. I had a moment with one of our social workers in the hospital, who at least within the context of the hospital, we have a great working relationship, and I am very fond of her, and we work very closely together. And she is African American, and race is not something we've ever talked about before. And in the wake of everything that's been going on, it just sort of naturally became a topic of discussion for us. And I felt very uncomfortable even bringing it up, but I had to. It was just the conversation led there, and I had to ask her. I mean, it was something simple like, how are you doing? How are things in where you live? And it was just the idea of being able to talk about it. And she actually laughed when I brought it up, because it was like she could tell how hard it was to even broach as a topic. And I think that's honestly, like, I can't speak for what my institution is really doing to change things, because I think it's too early to really tell. I think we've seen some wonderful moments. We had a white coats for Black Lives moment, which was fantastic and very powerful, but it's probably too soon to tell what types of changes, at least in my institution, are really happening. But on an individual level, it's just great to see, colleagues actually talking about this and actually, because I think that's where the change is going to come from, is from people actually saying, I don't like what's happening here and I need to do something about it.
Like individual clinicians acknowledging it and figuring out how to do better. Yeah, that's great. Thank you. Julie, I'll hand it back over to you. We have several questions in the chat.
Yeah, I'm enthralled in the chat as well. I'm so glad that you're going to make it available to everyone.
No, yeah, I will. And I'm fine to ask some of these questions if you want.
Yeah, that would say me moving up. So if you got them in front of you, rock and roll. Thank you, Natalie.
It's a very busy chat box today. And like I said, we will share this with anyone after. So if you have any resources that you'd like to share with the group, that would be great. You can actually put links in this box too, if there's any articles or anything you want to share that speaks to these things that we're talking about today. So someone asked, and I'm sorry if I miss your questions. Okay, so here's one. This is one that we get a lot too, because our social workers are, and I'm sure nurses are also dealing with this, but our social workers a lot of times, are trying to keep the bridge, I guess, between the families and the patients. So Susan asked, she'd be interested in hearing how you're dealing with technology issues. I have many caregivers who either do not have reliable internet access or are very unfamiliar with tech. So using things like Zoom is difficult or impossible because no one is able to go there and help them actually maneuver the technology because of concerns around COVID. So maybe you can talk a little bit about maybe what you've done to help, or you've seen at least some ideas. And I think we talked some earlier about that, but some things that you've done to maybe help patients and families, caregivers navigate that.
I can speak a little bit to this. So I work at Jefferson, which is in Philadelphia, which has fortunately invested in telehealth prior to the pandemic, very early on. With that being said, in oncology, we went from 40 visits a month to 1,800 telehealth visits the second week of COVID. So clearly we could have never been prepared for that increase in the volume. But we created a telehealth task force, which actually is outreaching to all of our patients who are being reassigned to telehealth visits. So essentially we tried to, at least early in the pandemic, anyone who wasn't getting chemo or radiation ideally would get a telehealth visit instead. And so this telehealth task force would reach out to the patient in advance, help them actually download what we have as MyChart, but like electronic medical record, which is the way that they access it, and or connect with a family member or someone else in the home who might be able to help them access the technology piece if there was some concerns of digital literacy. So it took a little bit of revamping some people's roles and their priorities, but it seemed to be helpful in increasing our ability to connect with patients during the time.
Eunita? I would be interested to hear what you've been doing in hospice, Eunita.
Yes, I was going to answer that. Pretty much a lot of similar things to what was just mentioned. And we found, that we do have a lot of patients and caregivers that aren't very technologically savvy, I should say. And so it has been a challenge. Many times, often we find ourselves, making lots of phone calls or trying to do the telehealth visits, which, most of our patients or caregivers are not, really familiar with things like Zoom. And so, but they are, for whatever reason, they seem to be pretty familiar with using the FaceTime on their telephones or their personal phones. So we have had a lot of success in terms of trying to do some of our visits in that manner. And, a lot of education, I think, is really important. Unfortunately, a lot of it does have to be done via telephone in a lot of those situations. And so we're just kind of constantly looking for other avenues to be able to get technology training across to our caregivers. But those are, it's very similar to what I think she's already doing or mentioned in her workplace.
Mm-hmm.
And we had a question come in actually privately to me, so I'm going to read it out. It's for all the panelists. How has the COVID-19 pandemic changed your perspectives on loss, both in the short term and in the long term, specifically with the threat of the job loss or loss of physical time with your family, friends, colleagues, social interactions, just overall sense of loss? Personally, for y'all.
Mm-hmm.
Well, I would have to say, Julie, for me personally, I think it's really kind of really forced me to look at, how do I want my future to look as far as, I've always been kind of a procrastinator when it comes to planning for the future and financially. And of course, I think I alluded to the fact that there have been really a lot of reduction in visits for not only our company, but others as well that are in the same business of home health and or hospice. And so that really kind of got my attention and really made me think about, well, if we do have a job loss, what do you do with that? Or am I prepared for that long term? What do we do with that? And I think really that not only with the reduction of visits in the short term and loss of revenue being significant, but I think also long term, I see some effects from that. And really a good example, I think, is like patients that are not having elective procedures right now for palliative care and for hospice. I think that's significant because if you consider the fact that an elective procedure to most people has very different meanings to us. It could involve someone putting off a cancer treatment, cancer type of surgery, those orthopedic surgeries, all those things I think can lead to people actually coming on board being much sicker and with very complex needs. And so long term, I think it's going to be very much a struggle, I think, within our profession to try to keep up and meet those needs.
So Becky, what are you thinking about as far as the, we were early on when we were planning this particular webinar, we started talking about essential positions, and I would like to call that one, and let's put it on the table because it's
I hate the language of, when this all started, who can work remotely, who needs to be in the office, who's essential, who's non-essential. And I really, really despise that language because we really are all essential. And I wish the conversation would transform to how can we provide the best quality care given the situations that we're in. And Certainly, concerns about job loss are real, and demonstrating our value and our impact to patients not only is true all the time as we try and grow programs and make sure we have supportive staff. I think social workers and anyone who's non-billable feels this sort of pressure to sort of prove yourself. But even more so in a pandemic where job loss is certainly a possibility and becomes more threatening. I think that kind of ability to show, our impact is greatly important.
So have you done anything as far as, managing that stress or that sense of loss, and, seeing your colleague may not be able to be employed tomorrow, but yet you are, how do you manage that guilt?
Yeah, sure. No, I think it's a challenge. I mean, luckily my team hasn't really had that experience, which is great. So I haven't had that experience firsthand, luckily. But I think the same kind of guilt exists with those who, my team who are going inpatient and those who are serving on the outpatient. So the same dichotomy can kind of exist in those two settings, as well as kind of the guilt I feel for my nurse practitioners and the physicians I work with who are seeing patient on the inpatient side, and really kind of considered more frontline workers than perhaps those of us on the outpatient. And, I think that's sort of another example of sort of this essential, non-essential dichotomy that we see.
Yeah, I think we should take just a better term, make a pact. If we're all essential, in the healthcare, palliative care of patients with serious illness. And it is a negative connotation. And, that brings us in, Natalie, I don't know if you want to bring up about the hero language that we were kind of talking about. You want to take that lead?
Sure, and I just want to let everyone know, I believe Yoonju has another commitment, but we can stay, if the speakers are okay with staying till about 4:15, so we can take some questions. Is that okay from the audience? Okay, and maybe what we'll do is we'll do one more question, and then we can open it up. We'll let people turn on their mics and talk to themselves a little bit. So one of the things we've heard, and actually someone put this in the chat box about, nurses were hired to help deal with the spike and then were laid off. In the same way, we saw a lot of social workers, even at the kind of the spike, were furloughed and deemed not essential to the treatment. They were kind of, and many of them were told to work from home, or, they're reduced pay, or, they just weren't part of their COVID treatment team. So for nurses and social workers, I think, do you see a problem with kind of this language of like, this, we call it hero language, do you, especially when you're not allowed to interact with patients, how do you, I guess, how can social workers and nurses kind of navigate that feelings of guilt, maybe feelings of survivor guilt or feelings of clinician guilt, maybe guilt about not being able to help even though they want to, or guilt that, they're not able to be there in the way they want to be. I don't know if you can speak to a little bit about that. That has come up a lot, at least in our conversations prior to this meeting today. So.
Can I speak? I do have to run off soon, but if I could just speak to that hero language, which I found problematic for a number of reasons. Some of the reasons you mentioned, Natalie, but also just sort of as a framework, the idea of a hero is very much tied to this individualistic idea of a savior. I mean, the heroes that we know, comic book heroes, the Superman, the Batman, they're all just these powerful individuals. And, at a very fundamental level, I feel like I need to push against this idea of individual versus collective. The one thing we learned from COVID is that there is interrelatedness in everything, in the ways in which, supply channels are happening with PPEs, in the ways in which, our zoo animals were much happier when human beings were not visiting, and, we cut down on carbon emissions. We're interrelated, and the interrelatedness should really speak to our collective efforts. And certainly, you know, part of what is getting us in trouble now in these, you know, continuous peaks is because we don't have a collective idea and identity about how to respond to this virus. And so the language of hero is very much setting apart an individual, whereas we know everyone is important. Like Becky said, everyone is essential, especially in this. And so whereas there has been a language of we're in it together, we haven't been in it together. And only certain people have been defined as essentials or heroes. And the heroic job that you need to do is to stay at home. That is your heroic job, to not see your grandmother. That is a really active heroism and sacrifice that's just as important for the person that's in the COVID bed, intubated. And you know, so there's that macro structure, but fundamentally, what happens if you're labeled a hero and this is just a job? Do you get to, you know, feel like, oh, I just don't want to be doing this? Do you get to feel that? Or does that get invalidated? What if you're really afraid of going to work, but you're a hero? Do you get your fears validated? Are you able to speak about it? You know, what if, as you said, you feel guilty because you're really not doing as much as you think you ought to be doing? There's so much emotional burden, and I'm not, you know, and it's curious to me, why are we giving this to these healthcare workers? Not that they're not doing wonderful jobs, but what is the underside of this hero language in which it really minimizes our collective efforts and really prioritizes certain people over others? And I feel like the whole narrative has to be really questioned because there's an underside.
That is such a great, usually like that's so, you just, I feel like fulfilled what I've failed to fulfill for many of my families in terms of, you know, we were talking earlier about the powerlessness that families feel with not being able to visit their loved ones, to not be able to be a physical support system for them. And to be quite honest with you, I think that's something that I personally haven't done as much as being able to tell them, you're actually doing your loved one and your community a very heroic thing by following the rules and by doing, and I think that's honestly at a public health level, that's what certain states have done better than others. I think, not to bring this all back to COVID, but I think some states have done a fabulous job, I think, with their public health officials of saying, we're making progress and we're doing great things and it's because of you. We're actually, you know, our numbers plateaued because of the you know, the actions, or in some cases, the lack of action that you've taken. And I think that's worth noting, you know, in terms, like my friend Elizabeth, sorry, quick shout out, my friend Elizabeth, who's a social worker at Augusta Health in Virginia. I used to work with her, and she brought up a good point that there is some positivity to the hero language here. I mean, maybe it's something practical like a discount that you get. It makes your life a little bit easier, makes it easier for you to do your work, and you know, and it makes your personal life a little bit less stressful. And one positive to the hero language is maybe it's that we're not using it in the right context. I mean, we know that there are, I mean, I agree with everything everybody said about essential workers. I hate that language so much. And there is a double-edged sword to it, but there is a role for, I mean, we all as community members have roles to play as heroes. And, you know, it may very well be, maybe the word shouldn't be hero necessarily, but maybe there is a role for something like it that, you know, in terms of, you know, the action you're taking has a, you know, is having a positive effect on me, you know. I'll stop there.
Yeah, thank you. I think Yunju had to go. She had another meeting.
Yeah, right, and Eunita did as well. So they said to thank everybody.
Yeah, maybe what we can do though is, I mean, there's 200 people here. If anyone has questions for Becky or Alex, you can unmute and ask, or put it in the chat and we'll ask, or maybe you have some words of wisdom to share with the larger group on what we've talked about today.
So Natalie, while that's kind of happening, so what was just said about the language that Anju just said, we have a recording of it, and it sure would be really nice to take it and have it transcribed into words so that we could all remind ourselves about the message that just got shared. You know, I think it's one of those pivotal times that you hear something and it touches your soul and it helps you understand and kind of put a perspective on things. And I think that was one of these moments that just happened. So that's your charge, Natalie. tape to text.
Yeah. We have that feature.
Yes, we do.
I just have to learn how to use it, but we have that feature. So, yeah, and this is recorded, this talk, so we will share it with those who've registered, at least, you know, at SWHPN, and I'm sure HPNA will do the same. So we're happy to, you know, if you missed the beginning of the meeting or whatever, we're happy to share the recording. Anyone have any questions for Alex or Becky, or want to share something before we close?
This is Teresa, and I work in hospice, and I'm a chaplain. And I know this has been mostly for nurses and social workers, but as chaplain, we've kind of walked the same journey as you all, and have experienced many of the same things. And I just wanted to say this has been helpful, and I especially appreciated Eugenia's latest comments because they really spoke. Anyway, there's a lot that has been going on in the hospice world, and I don't feel as if we have recognized how much of an effort those who work in hospice have, you know, faced in the face of COVID. So anyway, I just wanted to lift up and say thank you for all that people have shared today, because it really has also spoken to my heart as well.
Thank you.
So,
You know,
Thanks, Teresa.
glad to have a chaplain on board here.
yeah.
Other comments or questions or final thoughts that anyone would like to share?
I have a question for Becky.
Hi,
I'm
Anne.
from San Diego. I'm a inpatient COVID nurse on a cardiopulmonary unit. And Becky, I'm wondering how you talked about the use of medical students to feel that human connection that the patients so dearly miss. And I'm wondering it sounded very much like a great idea to me. And it's just something that I think in my organization, we can have volunteers do that versus nursing students or whatever. But how does the HIPAA policy come into play with that in terms of letting volunteers or nursing students talk to patients? I'm wondering how you guys handle that, so I know where to come from when I put this down to my leaders at the organization.
Yeah, I mean, I would recommend checking with your volunteer office to see kind of what the protocol is in terms of, you know, generally being able to get patients to have access to medical records, like what sort of the restrictions are and what clearances they might require in advance. We didn't do it with volunteers. We also have a buddy program in our cancer center as well that goes through the volunteer office. So there certainly are some limitations in terms of HIPAA and what they're able to do. But we really gave the people who are participating in the program very kind of minimal information. Essentially, sometimes it's just a name and a phone number. We were only doing this program in the oncology inpatient, so we were not trying to tackle the entire hospital, so it was a bit limited in that regard. I think the challenges that we really found were more that the turnover was so quick that it was difficult to kind of keep up with which patients were still on the floor, which ones weren't, some of kind of the logistical pieces here. So that was a little bit of a kind of the challenge organizationally. But we were able just to sort of go through our normal protocol with any type of volunteer to be able to get people cleared to participate.
Okay, thank you so much.
Hello, could I say something?
Sure.
So my name is Angela and I'm a hospice nurse from California. So what I want to say is the COVID-19 has really pushed the envelope for us to allow family to see their loved ones, in the fact that now we have a lot of COVID in the nursing homes here. So sometimes I can have a nursing home or board and care allow the family to come in one at a time when the patient has passed. But what I have noticed mostly is families are asking me to meet the mortuary, the person to do the body pickup outside so that they can have the body pickup. They will open the bag so that they can view their loved ones before they leave, because there is that dissonance where, you know, they haven't been able to see them and they're dead and they need to have that view. So the way that we have had to be creative in our practices, or to sing for those that have died, or to stand vigil where the family can't. So I just want to honor all of our efforts, our creative efforts.
Mm.
So.
Mm.
I'm so glad you said that. I know that wasn't easy to say. Thanks for saying that.
Yeah, thank you. This is Grace Christ. I had another question around nursing. I've heard that also about the severe decline in dementia patients because of the lack of contact in many different facilities. So have people had success in using FaceTime to connect them with their families at all? Or is that not possible? FaceTime's the simpler, you know, and yet you can see the face, you know. It's a simpler method, but just a thought, you know, but I've heard that a lot in all nursing homes, that this, you notice this severe decline in people who have dementia or Alzheimer's.
Well, what I notice is because they have their Alzheimer's, they are confused by the FaceTime, or they're confused by suddenly hearing the voice. Or they're mad because the person hasn't visited them, and they don't understand why they haven't visited them. And then now, why would they talk to me, or why should I pay attention to them on the computer?
So it's complicated.
So what you think is going to make them comfort them sometimes then just adds that, in my experience, to their confusion.
Yeah, thank you.
Well, thank you, everyone. And before we close, we actually have Ginger Marshall, who is HPNA's our CEO for HPNA and HPCC and HPNF. And this is actually, this entire webinar roundtable panel discussion was kind of a brainchild of Ginger, you know, right as COVID was first starting to surface and we were seeing the interconnectedness of our two disciplines. And so from initial thought on an afternoon conversation to over 350 people on a webinar, Ginger, thank you for bringing it forward, and we can turn it over to you to close us today.
Thanks a lot, Jolie. So Natalie, can you also make Jessica a co-host so we can see her smiling face here somewhere? Jessica is, of course, the executive director, there she is, for SWHPN. And the thing that I think Jessica and I are most proud of is this actually came from a brainstorming session that Jessica and I had together. Jessica reached out and said, let's start doing monthly calls. I said, great idea. And then we were talking and we said, we should do a webinar together. And the wonderful thing about it is the American Nurses Association heard about this great idea of bringing two specialties together to work on a joint venture. And they were so impressed that they actually sponsored this webinar today. So we are very, very grateful for their support of this. And I will make sure everyone knows that we're planning on doing much more of this in the future. We are going to be scheduling at least 3 joint webinars for 2021 in which both SWHPN and HPNA will be offering CEs for it. I love seeing the amount of chats on there where somebody said, we should make this a monthly event. And I'm thinking, oh my gosh, I love that idea. It would be a lot of work, but it may just be worth it. So just, I wanted to give you the opportunity to say something too.
Sure, thank you. And thank you everyone for tuning in. I mean, we were just so overwhelmed. I think sometimes you plan these and you hope, you know, well, 15 people register, you know, 50 people. And so the response was really great. And I love that there were chaplains involved too. And maybe we keep this as a kind of an ongoing way to keep the interdisciplinary conversations going. I just think there were so many great nuggets of wisdom shared by the panelists and also in the chat. There's clearly a need for us to get together and share more often. And for whatever way Ginger and I can help do that, I think would be really, really awesome.
Yeah, more to come.
More to come.
I can't.
Thank you.
Thank you guys so much. And yeah, I just to reiterate, any opportunity to get to talk to our social work colleagues and work with them, I'm just thrilled I had the chance to, and absolutely on board with the continued collaboration with these webinars. So thank you.
I love that in the chat, a couple of people have posted that this is essential, just kind of playing on the conversation, which is just so great. It really is just the ability to take the time and the space to be together and share all of this has been really, really wonderful. So awesome. Thank you, Alex. Thank you, Becky. Thank you, Julie and Natalie for moderating. And we will follow up with lots of additional information and details.
Take care, everybody.
Thank you so much.
Thank you for the collaboration, everyone.
Thank you.
Yeah.
Thank you.
How are you doing? How you doing, Natalie? Wow, it was great. Wow, it was fantastic.
That was really good.
It was really good. Oh man, just great. Everyone, Becky's still on. Great. Fabulous.
Becky and Julie, I think Alex just left, but thank you.
Okay.
Thank you.
Yep,
so
everybody
much.
take care. Thanks, everyone.
Thank you.
You as well.
I thought
Natalie, I will.
Natalie, good job. Good job, Natalie.
All right. I'll
Okay.
Bye, guys.
Sounds good. Sounds good.
Okay.
Back to you.